Hi everyone, welcome to my channel. Today we're going to talk about chest pain. I am going to go over acute coronary syndrome that includes angina, non-STEMI versus STEMI. What are the risk factors? How to identify if a patient has chest pain? What is a clinical presentation? The RN scope of practice, management, and care. My name is Christina Velasco, nurse practitioner. Let's get started. So on the top, acute coronary syndrome is kind of like an umbrella term. I use that as a concept because I see it as when there is impediment of blood flow as a result of plaque, it results in a reduction of blood supply to the heart. So within your heart, you have 4 chambers. On the left-hand side, I drew a picture of a heart with an aorta. You have your right and your left main artery. Within that, you have your LAD and your left circ. Those are your 2 main coronary vessels. Your LAD is your left anterior descending artery, and then your left circumflex artery. So, when those get occluded, you've probably heard of the term atherosclerosis. So on the top here, I drew 3 vessels so you can have an understanding. So the top vessel is normal, meaning there's no plaque, the blood is able to flow freely through. Beneath that, there is plaque buildup, so there is impairment where the blood is not able to flow as freely as it was able to with a normal vessel. And then below that one, the plaque is completely occluding the vessel to where there is blockage. And when there is blockage, there is ischemic tissue to the heart, which can result in a heart attack. So how are we able to identify who's at risk and who's not? So we have 2 terms that we use. We have non-modifiable and modifiable risk factors, which is always discussed or mentioned in NCLEX. So your non-modifiable risk factors are things that you are not able to change, which is age, sex, or family history. Modifiable risk factors would be hypertension, diabetes mellitus, obesity, living a sedentary lifestyle, smoking, and poor diet can all contribute to buildup of plaque. So clinical presentation. The clinical presentation would be your patient that comes in with chest pain. He typically explains of having an elephant sitting on his chest, or he's feeling diaphoretic or nausea, or it can be very vague symptoms like the female that comes in and she's having indigestion. So it could be very textbook appearing type of patient, or it could be very vague. That's why your assessment skills are very important. On the left-hand side, I drew a picture of an umbrella because I kind of think of acute coronary syndrome as a coverage term, meaning it covers a term for angina, non-STEMI, and STEMI. And what I mean by that is your patient that has angina can have chest pain, however, typically it resolves with rest. When it's not resolving with rest and it doesn't go away, it can also be a form of STEMI, which would be a heart attack, or a non-STEMI if it's greater than 12 hours, which I'll go over in detail. So your patient that comes in with chest pain, he's diaphoretic, he's feeling nauseous, you set him up on the monitor, you get a set of vital signs. Typically, a family member is usually with the patient. So you want to start screening them. What I always use is S.I.M.P.L.E. S is for signs and symptoms. A is for allergies. M are for recent medications. Have they taken anything? Are they on high blood pressure medication? Do they have a prescription of nitroglycerin? If so, when was their last dose? You want to know pertinent history, such as have they had a stroke in the past? Do they have any deficits as far as their baseline, meaning left-sided deficit to where they're having weakness? When was the last meal? Because they may be a patient that may have to go to cath lab or surgery. And then what were the events leading to this? Like what happened? For example, maybe they were having some chest pain early in the morning. It resolved with rest. 6 hours later, the pain occurred again. Patient was resting, but it didn't resolve. The chest pain persisted. So then they came into the emergency room for further evaluation. So your patient that comes in with this, by now you have them on the monitor, you are checking their vitals, you run a 12-lead EKG. Typical treatment, what I have always used is an acronym called M.O.N.A. M stands for morphine, O stands for oxygen, N stands for nitroglycerin, and A is for aspirin. This is a very simple term, and this is typically your go-to, what you use for the patient that presents with chest pain. So for the RN scope of practice, you've got your vitals, you're looking at the 12-lead EKG, you want to look for ST elevation, and the ED attending will also review this as well. You also want to look at your labs. You want to see what you need to order, which would be cardiac markers, your coags, lipids, glucose, electrolytes. In addition to that, you also want to screen them for fibrinolytic therapy if they are a candidate. For ACLS guidelines, time is tissue, you want to think. So the time that the patient comes into the door, you want to be able to know that if they are a candidate and they need to go to the cath lab, you have 90 minutes, meaning they refer to it as the door to the balloon for a percutaneous intervention would be 90 minutes. If they are a candidate for fibrinolytic therapy, door to the needle, the goal is typically 30 minutes. However, time is tissue. If they exceeded the 12-hour mark or they are high risk, unstable angina, and they were a non-STEMI, you would like to consider starting them on a nitroglycerin drip, a heparin drip, maybe PO beta blockers, some Plavix, and admitting them to a monitored bed. When they are monitored, the doctor will typically review the medications. If they haven't already been added, they'll consider adding on an ACE, an ARB, and a statin therapy medication. Again, thank you so much for watching. Make sure to subscribe and hit that like button. Take care. Bye-bye.